Hello and welcome to today's webcast, AAD NPF Guidelines of Care for the Management and Treatment of Psoriasis and Comorbidities. My name is Bev Bromfield and I'll be your moderator for today's presentation. Before we begin, I'd like to acknowledge our sponsors, Bausch Foundation, Celgene, and Novartis for their support of the Psoriasis Guidelines webinar series, for which this webinar is part of. Look for additional webinars in this series throughout the year as new guidelines are released. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have an opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. We'll collect these and address as many as possible during Dr. Menter's Q&A session today. Since some of you may be new to the Foundation, here's a little background about who we are, our mission, and what we do. On July 1st, 2019, the National Psoriasis Foundation launched a new strategic plan which guides everything we do as an organization. To achieve our mission, the following goals were identified: lead collaborative and transformational research in psoriatic disease, improve health outcomes by increasing the lifespan and health of individuals living with psoriatic disease, secure resources necessary to achieve our mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis and moving towards a better understanding of what it means to live with psoriatic disease. If you have psoriatic disease, you can help accelerate our efforts towards collaborative and transformational research that leads to a greater understanding of the disease and a cure by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientists. Answer questions and view your data, along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve the health of individuals living with psoriatic disease through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 option 1 or visit psoriasis.org/navigation center. To help the Foundation achieve its goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about the AAD NPF guidelines, overall purpose, how they were developed, and what the guidelines mean to you as a patient, how the guidelines impact the treatment of psoriasis in relation to concurrent health issues such as psoriatic arthritis, cardiovascular disease, metabolic syndrome, mental health, and other concerns. Impact of such guidelines on discussions with your healthcare provider, resources to help gain a better understanding of psoriatic disease, and available treatment options. Now I'd like to introduce you to our speaker, Dr. Alan Menter. Dr. Menter is chairman of the Division of Dermatology and director of the Dermatology Residency Program at Baylor, Scott & White in Dallas, Texas. He is one of the most highly recognized dermatologists around the world. Dr. Menter is the director of the Baylor Dermatology Research Center in Dallas. He has long held interest in psoriasis and psoriatic disease research. His research has examined everything from ultraviolet phototherapy, biologic therapy, to the mapping of genes. In 1994, he co-authored the first gene discovery for psoriasis. Dr. Menter owns a clinical practice, Texas Dermatology Associates, based in Dallas and Mansfield, Texas. He helped found the International Psoriasis Council to raise international awareness of psoriasis as a serious disease that significantly impacts quality of life. Dr. Menter served as a co-chair for the development of the joint American Academy of Dermatology and the National Psoriasis Foundation Guidelines of Care for the Management and Treatment of Psoriasis, which you'll learn more about today. This is the first of 6 webinars about the guidelines. It is my honor to welcome Dr. Menter as today's webinar speaker.
Well, I very much appreciate that warm introduction, and I appreciate the National Psoriasis Foundation and all the patients on the line taking the time to listen to this, talk a little bit about comorbidities and management and treatment of psoriasis. From a personal perspective, I've been in the field of psoriasis for the last 40 years, but I have made very sure that I have no financial ownership in any pharmaceutical company and therefore have no financial relationship to disclose. Now, relating to the next slide, that we will discuss the guidelines that we've created. This guideline committee that we created with the American Academy of Dermatology that I co-chair with my friend and colleague, Dr. Craig Elmbitz, and you can see here on this slide, 20 to 25 dermatologists around the country have helped us put these guidelines together, and the guidelines were published for the first time in the Journal of the American Academy of Dermatology in April this past year. And there was 2 guidelines published, the one on comorbidities and the other one was on all the current biologic agents, which are now 11 that are available for psoriasis. So the guidelines in the bottom half of the slide statement addresses the management and how we can manage the different comorbid conditions associated with psoriasis, such as mental health, psychosocial wellness, quality of life, and I'll run through all the physical issues and particularly relating to the cardiovascular field as well. So this is the list and the purpose of the guidelines. Why did we create guidelines? In the old days, 40 years ago, it was felt that psoriasis was purely a skin disease. Now we recognize it has multiple internal extracutaneous manifestations, which we'll run through. So we took a definition of psoriasis, which is the standard definition of psoriasis, relating to psoriasis being an inflammatory, immune-mediated disease. In other words, the immune system is not well controlled in psoriasis. The body surface area relates to, in your hand, from your wrist to the tips of your fingers and your tips of your thumb, is 1% of your body. So less than 3% is considered mild, 3 to 10% is moderate, and 10% is severe. But all the biologic agents that are approved for psoriasis, the 11 biologic agents in the U.S. that are approved, all have the label moderate-severe psoriasis. So we'll talk a little bit about the emotional impact of psoriasis and the other systemic disease that are associated with psoriasis. So here is a list of the comorbid conditions that we published. And the big question, I'll go through this list quickly in the interest of time, but the issue is how do you as a patient and how does your physician, your dermatologist, screen for all these potential comorbid conditions associated with psoriasis? Joint disease follows psoriasis normally by 10 years. And cardiovascular disease is a huge, big issue. One of the most important issues relating to psoriasis. Psoriasis patients do have a higher risk of heart disease as well. Metabolic syndrome, we'll discuss what the metabolic syndrome is. Mental health, the depression issue in our psoriasis population. Lifestyle choices. Can the average psoriasis patient live a normal lifestyle, go to picnics, wear short pants, short sleeves, etc.? All very important. On the right-hand side of the slide, risk of malignancy, lymphoma, renal disease, sleep apnea, we have problems with not being able to sleep properly, lung disease, uveitis, which is the eye, and hepatic disease, which is not just driven by increased alcohol, but by the metabolic syndrome. So all these 12 issues are tied into psoriasis, and by controlling the psoriasis better, we believe we can reduce the comorbid conditions associated with psoriasis. Let's talk about psoriatic joint disease. 1 out of 3 people get psoriatic joint disease, as I said, 10 to 15 years after the onset of their skin disease. So you and your dermatologist always needs to be on the lookout, because if left untreated, about over 50% of patients' joints will become permanently destroyed. We cannot allow that to happen. So the joints can be the small joints of the hands and feet, what we call dactylitis, the large joints of the hips, the knees, the elbows, all can be involved either individually or collectively. And basically, dactylitis is your inflammation of your tendons that attach to the bone, like the Achilles tendon. We always look for that to see the early signs of psoriatic joint disease. So we have to educate our patients, discuss the quality of life, and the most important question that you as patients need to understand is, do you have stiffness in any of your joints when you wake up in the morning? Early morning joint stiffness is a very important early manifestation of joint disease. So we have to work with our rheumatologists, work with our patients, and we cannot allow patients to delay the diagnosis because it can destroy the joints permanently. Now, cardiovascular disease. This is the one area that potentially can shorten the lifespan of a psoriasis patient who has more severe disease, because the inflammation that we get in our skin, the redness, the thickness, the scaling, is not driven by skin itself. It is driven by inflammation in the bloodstream, and that inflammation also can affect the coronary arteries. And we understand this, that the inflammation is coming out of the blood vessels, into the skin, into the coronary arteries, and into all your blood vessels. So coronary artery disease is a major problem that we have to recognize and have to treat appropriately. And the big issue now is, with all our 11 biologic drugs, will our 11 biologic drugs, by improving the skin, help improve cardiovascular disease? And all the trend says, yes, it does. All right. So the risk of cardiovascular events, a major adverse cardiac event, MACE, as you can see at the bottom third of the slide, is more severe in patients with more severe psoriasis. So the bottom line here, the MI risk, a myocardial infarction, a heart attack, is slightly increased in mild disease, but significantly more increased in severe psoriasis. So we believe that by controlling the inflammation in the skin with appropriate therapy, we hopefully will be able to reduce cardiovascular disease in all our patients. This is a very interesting slide. My dear friend, Dr. Menter, at the bottom left, you can see it, who is a cardiologist who has a huge big grant from the National Institute of Health just to study cardiovascular disease in our psoriasis population. Here is a stain that he does. On the left-hand side is a normal patient. On the right-hand side, you can see all the staining going all the way down into the legs, the lines going down to the legs. That's your arteries in your legs going all the way down to the feet. Goes into the liver, goes into the kidneys, goes into the carotid arteries going up into your brain, into the coronary arteries, whereas patients without psoriasis do not have this degree of staining. So this is a very, very important issue that Dr. Menter has taught us, and we've done studies with Dr. Menter to show that patients who have a significant psoriasis have a higher risk of coronary artery disease. We've done that study with him. So, will our biologic drugs reduce the risk of inflammation, systemic inflammation? And the answer is almost certainly yes, it will. So the cardiovascular risk factors, the blood pressure, the metabolic syndrome affects blood pressure, blood glucose, cholesterol, triglycerides, and we do now know that biologic therapy, this is a small number of patients, can potentially reduce this risk. And at the very bottom line in this slide, you can see a study that's done that with TNF-alpha agents, which we have 4, Enbrel, Humira, Remicade, Cimzia, that there is a slight reduction in cardiovascular events by using a drug like the TNF-alpha drug. Now, this is the coronary artery. It's a very, very well done slide of the coronary artery, and you can see the cholesterol deposits, lipid-rich coronary artery plaque following 1 year. On the left-hand side, before the therapy. On the right-hand side, you can see a significant reduction in the size of that patch, the plaque within the coronary artery, following 1 year of high-quality therapy using a biologic agent to reduce the coronary artery disease. So again, please remember, as a patient, you are dealing with an internal disease, not just a skin disease. So this is the metabolic syndrome. The metabolic syndrome contains multiple different factors associated with it. You can see all the different arrows. Hypertension, high blood pressure, high blood sugar, insulin resistance. The majority of patients with the metabolic syndrome who have psoriasis are more heavy than the patients without it. And the metabolic syndrome can then lead, on the bottom right-hand side, you can see this, to cardiovascular disease, strokes, and type 2 diabetes, etc. So we have to learn to control the metabolic syndrome in addition to controlling the psoriasis and the psoriatic arthritis by working with our primary care physicians and our cardiologists to reduce high blood pressure, blood sugar, cholesterol, inflammation in the bloodstream, diabetes. We will help control psoriasis and help control all the cardiovascular issues as well. So the metabolic syndrome, this is the definition, and it's thought to be due to insulin resistance, you can see on the bottom right here, and adipose tissues, fat cells, and the higher the number of fat cells in your body, the increased risk of the metabolic syndrome, the blood pressure issues, cholesterol issues, the triglyceride issues, fatty liver, heart disease. All of these are aspects of what we call the metabolic syndrome. And your primary care physician and your heart disease doctor now understands the risk that psoriasis has in creating all these issues in the metabolic syndrome. This is a busy slide, but these are studies that have been done by the American Heart Association, by the American Diabetes Association, looking at all the issues relating to metabolic syndrome. And some medication that we use in the bottom left-hand side, some medications that we treat psoriasis with orally, like cyclosporin, which works well, but we can only use it for a short term because it can cause blood pressure issues. So we do have to be cautious with drugs that can potentially aggravate this. So cholesterol, is part of the deposit in the coronary arteries and in your blood vessels, and we are sincerely hoping by improving your psoriasis, we'll be improving all these issues relating to the metabolic syndrome. Mental health. How difficult is it to live with psoriasis? We recognize this. And the second bullet point in this slide talks about depression, anxiety with psoriasis. There's significantly higher risk of depression in our psoriasis population. Very definite. And it's been well shown in the bottom third bullet on this slide that by using a biologic drug to clear your psoriasis, it has a dramatic effect on the patient's depression, whereas systemic therapy and phototherapy are less effective but still do have an effect. So we do have to recognize that people with psoriasis have a slightly higher risk of depression, and even if they're not treated properly and correctly, and they have to live, particularly as young people, with their psoriasis, they do have a higher risk of thinking about suicide. So our treatments today are reducing this depression and suicidal issue very significantly. So what about your lifestyle choices? We recognize that comorbidities, all the 12 comorbid conditions associated with psoriasis, the metabolic syndrome, does affect your personal behavior. Can you get out and exercise when you have psoriasis on your arms and legs? Smoking is higher risk in our psoriasis population because people are depressed and they smoke more and they use more alcohol. So we definitely need to improve the psoriasis to reduce the depression so that your lifestyle can be normal. You can have all normal interpersonal relationships. You can take the kids to the swimming pool. You don't have to miss a picnic for your business, your firm. You can go wherever you want to do and reduce your smoking and reduce the alcohol consumption as your psoriasis improves. We've seen this all the time as we now have these excellent therapies for psoriasis. Inflammatory bowel disease. The two diseases that relate to inflammatory bowel disease is one, Crohn's disease, and two, ulcerative colitis. These are inflammations, similar inflammation, skin inflammation, but it's in the gastrointestinal tract, which you can see on the right-hand side. And the two diseases have a higher risk in psoriasis. 2 in 1,000 for Crohn's, 1 in 1,000 for ulcerative colitis. And it is even higher in people who have psoriatic joint disease. And it's interesting that the TNF-alpha drugs that we have, the 4 that I mentioned, not only can improve skin and joints, but have a positive effect on inflammatory bowel disease. One, at the bottom line, possible worsening of inflammatory bowel disease with the use of IL-17 inhibitors. We have 3 IL-17 blockers now, and there's a very slight risk of them exacerbating inflammatory bowel disease. So we do have to be on the lookout for that. So other comorbid conditions that we haven't discussed, malignancy, lymphomas, renal disease, very, very low incidence, but a slight sleep apnea. Patients do have a slight problem. You can see the patient on the bottom left with his left eye being red and inflamed. That's what we call uveitis, which is UV as part of your eyes. And we get rare cases of patients who have red eyes like this as a result of the systemic nature of psoriasis. Slide number 2 on comorbid conditions: lung disease, chronic obstructive pulmonary disease, hepatic disease, where you get fatty liver, not caused by alcohol, but caused by the metabolic syndrome that's part of psoriasis, which builds up extra amount of fat in your liver cells, which can cause liver disease. So what is the role of the dermatologist in this systemic disease? Number one, we have to educate our patients about all the issues relating to signs and symptoms of skin and joints. We have to look for joint disease because it comes 10 years after skin disease. So the average patient who gets early joint disease, which is 1 out of 3 people with psoriasis, does develop joint disease 10 years later, will be seeing his or her dermatologist. And between the patient and the dermatologist, assessing early morning joint stiffness by looking at the fingers, the toes, the big joints, the Achilles tendon, we have to try and develop an early diagnosis of psoriatic arthritis. We have to look at skin, the joints, and at all the internal diseases that we have and work with our primary care physicians, work with our cardiologists, make sure the blood glucose is well controlled, blood cholesterol is well controlled, and that patients, if possible, can lose weight if they're significantly overweight. Now, you patients need to be educated about your psoriasis, and that's a major role that the National Psoriasis Foundation takes. Try and maintain a healthy lifestyle, reduce your alcohol, reduce your smoking, try and exercise, try and lose weight if possible. See your primary care physician so that your metabolic syndrome issues, your cholesterol, your blood glucose, your heart disease, all can be adequately evaluated. And look at your psoriasis. The better you get your psoriasis, the more likely you are not to have any other internal disease. So play an active role, as this fourth bullet says here, in your healthcare decision-making process. We are very fortunate now to have such wonderful new drugs for our treatment of psoriasis. So setting treatment goals, be honest with your dermatologist. You want to see your body surface area, if it's 10, 15, 20% at the outset, you want to see that 3 months' time of treatment to get below 1%. So the hand on the right-hand side, if you put your fingers and your thumb together, starting from the wrist, going to the tips of the fingers and the thumb, that's 1% of your body surface area. So if you have a few patches, 3 or 4 patches, will add up to 1%. You want to get below that. And that is the goal that we, as patients and as dermatologists, need to work together to improve your lifestyle and reduce the comorbidities in psoriasis by getting your psoriasis almost totally clear. And we now have the drugs that can do that. So the guidelines that we in the American Academy created with the National Psoriasis Foundation, as I said, the first guidelines were shown in April. This was comorbid conditions, which we discussed. All our 11 biologic drugs, the second one. And just this past month, we released guidelines for phototherapy. So 3 guidelines have been released within the last 3 or 4 months. What's next? You can see the 3 further guidelines that we're going to have available. Pediatric psoriasis, children, young adolescents, topical therapy, which everybody uses, and non-biologic systemic agents. We have multiple oral agents with new agents pending that will sincerely hope, just like the biologic agents, the injectable agents, these new oral agents will also have a very positive effect on improving psoriasis. All right, so I think hopefully I haven't spent too much time. We now certainly am available here online for any questions that you may have. Thank you very much for attending.
Thank you, Dr. Menter, for your presentation and your insights about related health conditions associated with psoriatic disease. We do have a few questions for you. I know your time's limited. The first question is, why are most people not told about the links between psoriasis and other serious health conditions? I wasn't told until recently.
That's a very important question because, as I said from the beginning of my talk, the majority of patients and physicians, either dermatologists or non-dermatologists, never consider psoriasis as anything else but a skin disease. But we now have to recognize that the inflammation that is triggering your redness and your thickness and your scaling, your psoriasis patch, is coming from the blood circulation to the skin, and it also causes inflammation in other areas of your body, including the heart. So we have to understand that psoriasis no longer can be considered purely a skin disease. It is what we call a systemic, internal, immune-mediated disease. Just like lupus is, just like rheumatoid arthritis is, just like Crohn's disease is, psoriasis is now part of the systemic, internal immunological disorders.
That's a terrific answer, Dr. Menter. Another question, what causes a greater concern for future health risks? Psoriasis or the medications we take to control it?
You know, we are very fortunate now in having new medications that target a specific cytokine, which is a chemical. There's a whole circuit of cytokines which causes psoriasis. Now we have 11 drugs that target specific chemical in your bloodstream, cytokine, what we call. The rest of your immune system is left totally intact. So we are no longer suppressing your immune system. The term is modulate. Modulate means bringing it back to normal. And I tell all patients, when patients get worried, say, doctor, you're going to suppress my immune system. You're going to cause cancer. You're going to cause infections. I show them the term modulate. We are no longer suppressing your immune system. We are targeting specific cytokines, chemicals in your bloodstream that are increasing psoriasis, bringing it back to normal, and the rest of your immune system is left intact. So the risk of major side effect is dramatically being reduced with our new biologic agent. So you should feel much more comfortable, because if you don't treat your psoriasis, the inflammation is going to attack organs in your body and cause more side effects than the drug will ever cause.
Okay, thank you, Dr. Menter. Do you have time for one more question?
Yes, certainly, please.
Okay. My blood vessels feel inflamed. Can this be due to psoriatic disease?
Very much indeed. As I've just said, psoriasis is an internal disease that comes out of the circulation. So as a result thereof, your blood vessels in certain parts of the body, both internally and externally, are going to be more inflamed. That is going to certainly make you recognize that inflammation is not just in the skin, it's coming out of the blood vessels, which are inflamed with psoriasis. And we have to modulate that. We have to reduce that, and hence make you feel totally comfortable. Your blood vessels are no longer inflamed, your skin is no longer inflamed, your heart disease can be reduced, your diabetes, your arthritis, all the comorbid conditions are related to inflammation in your bloodstream. And by improving it, by reducing it, we will make you live a happy and normal life.
Thank you so much, Dr. Menter, for providing such an amazing presentation. We appreciate your time today and for sharing your expertise about the AAD NPF guidelines of care for the management and treatment of psoriasis and comorbidities.
It's a real pleasure. Thank you for having me. Thank you, everybody.
In addition to today's webinar, podcasts are also available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. Upcoming podcasts address rapid relief for psoriasis flares, pregnancy and psoriatic disease, and guidelines for use of biologics. Today's podcast, released earlier this morning, addresses options for rapid relief of flares. You can also hear more about related health conditions with podcast number 32 by Dr. Peck, a colleague of Dr. Menter's, also with Texas Dermatology Associates. Contact the Patient Navigation Center if you still have questions, would like additional information about treatment options, finding a physician, or are having issues with accessing treatments. Contact the Patient Navigation Center by phone, email, live chat, or Skype. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. I'd like to again extend a sincere thank you to our sponsors, Bausch Foundation, Celgene, and Novartis, for their support of this webinar series. Please watch for another Guidelines webinar soon. Finally, you can access our webcast archive at psoriasis.org/webcasts. This concludes our presentation today. Thank you for attending.